Hey, Wedgie.
Hey there, Phil.
We'll give everyone a few minutes, maybe till like 2-3 minutes after the bottom of the hour.
Sounds good.
Okay. I'm on another call, so I may have to hit in and out, but I'll do my best.
Perfect.
All right, guys, I'll say hello to everyone. Hope everyone's doing well. Excited for our next lecture here. We've got Dr. Divi joining us today to talk about spinal instrumentation. And for those of you who haven't met Dr. Divi yet, he's one of our new partners in our practice. He just started with us in September. And we're really excited to have him here. And he's going to give us an overview today on spine instrumentation. And that's a pretty big topic. And I look forward to seeing what he wants to share with us. So Sri, I'll pass it over to you.
All right, great. Thanks for the intro. We'll start sharing my screen here.
I didn't do a great intro. I apologize. So Sri joined us from Jefferson. He was a Rothman Fellow. He was a University of Chicago resident before that. He started with us in September, and he's sort of taking on an equal share of the clinical practice with us in terms of adult spine across deformity, trauma, tumor, and it's been a really great addition to our fellowship. So sorry to cut you short there, Sri, but that's it.
Not at all. It's been nice working with like kind of all the residents and fellows here. I think the only person I haven't met is Hamo, but I recognize him from like our group chat. So thanks for joining. So I'll just give a kind of a brief overview of our spine instrumentation techniques. Because it's such a broad topic, I kind of decided to focus on probably the more relevant ones for as residents and fellows, and you know, mainly focusing on posterior techniques. So there's a lot of things like, you know, techniques for corpectomy or, you know, intercervical, which is a little bit more routine. I kind of left out, but hopefully we could get into that a little bit more as we go on throughout those lecture series. So one of the things is we'll say, why do we need to know our anatomy in depth, and why do we need to know our technique carefully? Why can't we just use navigation for everything? I mean, you could, but isn't technology our friend? I mean, yeah, it should be, could be, and also it's going to rebel at you at some point. So, you know, open and floor techniques are kind of the foundation of spine surgical techniques, and technology can enhance our decision making, but does not replace kind of open technical skills. At the end of the day, you know, you should be able to use your knowledge of open anatomy to try to find, you know, find a salvage technique, or, you know, bail yourself out if you're in trouble. This year's kind of one of my favorite is from Braveheart. He says, before you can use this, you must learn to use this, and he points to his head, and you just replace the sword with a, you know, navigated probe, same thing. So we'll just talk about quickly evolution of instrumentation, pedicle screw fixation, which is kind of a workhorse approach for instrumentation. And then we'll just kind of go down the spine, kind of march down from the occiput and cervical, which is pretty complex, thoracolumbar, which is more routine for us, and then sacral iliac fixation, which we use in certain situations. So as some of the residents and me, myself, I'm not really familiar with because we haven't seen these techniques a lot, but over to the left, you see what are called Lukey rods and, wiring techniques. So basically, you can think of instrumentation as being broken into rigid fixation and non-rigid fixation. In the past, the first documented instrumentation for the spine was like in the 1890s or early 1900s. And it was initially, I think, documented in Texas for a cervical fracture dislocation, and then mainly found its use, throughout Asia and here as well, I think, for TB. So Pott's disease was the main kind of advent of using instrumentation because you have crazy deformities and that you need to correct. So this is an example of even before instrumentation, you could do uninstrumented fusion. I'm sure you guys have heard of that. So basically you'd try to lay down bone graft along the push out gutters, and then to stabilize them, you'd brace them. So you're relying on a patient being braced as the immobilization. You can imagine there's a lot of motion there, right? Even if you're externally immobilizing them, internally, there's still a lot of motion. Here you have on the left, like these thing called Lukey rods with spinous process and laminar wiring to hold the vertebral column, posterior vertebral column rigidly to these big rods. Then you see next to it here, this is a Harrington rod. I've never actually seen one in surgery, but I think, as Dr. Patel probably mentioned before, that we used to take a lot of these out because they were put in for lots of reasons, and they caused a lot of flat back deformities. So they were great at sort of scoliosis correction, but they weren't so great at sort of restoring anatomical alignment with like lordosis. So they found a lot of use back in the 80s, I think, and then sort of fell out of favor as other instrumentation techniques improved. Other things you can see here, this is probably the original kind of application of wiring in the cervical spine. It's kind of to rigidly immobilize, or sorry, non-rigidly immobilize the cervical spine using kind of techniques of wiring to hold it together. Then you move on to these other things, kind of like screws through the facet joints. I've seen these in x-rays and wondered what they were. You can imagine trying to immobilize the lumbar spine by putting the screws through the facet fixation. You can imagine doesn't immobilize as well as, let's say, a pedicle screw. And then you might have seen these in ped surgery, where it's still commonly used, where you have hooks at the bottom or top of constructs. You can apply a hook underneath the lamina up to the pedicle, so it's pushing on the pedicle. You can do it transverse process hook, or infralaminar or supralaminar hooks as well. But the mainstay now since the 90s has been pedicle screw fixation, because it's the only way to attain 3-column fixation of the spinal column. And it allows, and when you do that, it allows you to do a lot of things with the spine. It can let you effectively distract, compress, and translate and rotate the spine, and then do other things like create lordosis with the combination of these techniques. Here's like an example of a scoliosis patient where with scoliosis correction and derotational maneuver, you're able to straighten it out a lot. So pretty powerful way of maneuvering the spine. 3 things to consider always when you place a pedicle screw. Number 1, where is it? So this starts with meticulous exposure and using your surface anatomy as a guide. And with younger healthy patients, and especially like trauma patients, it's great. It's so easy, you'd think. And then, but when you start getting into like older patients with let's say like inflammatory disorders like either rheumatoid or DISH or just really hypertrophic joints and distorted anatomy, it can be pretty hard. You can get very lost and confused quick. So fluoroscopy or imaging intraop can help you with that. But at the end of the day, you need to know where to expect the anatomy. Otherwise, it won't be of as much help. You need to know where the pedicle is going, so you need to know where it starts. on the dorsal kind of surface and know where it's going. This is different in each person. That's why you need to carefully look at preoperative imaging. And then you need to also you need to see if there's any structures in the way, and if there's any anatomical structures at risk, like blood vessels or nerve roots. This is one thing I just kind of put in there as an aside. So, mainly kind of like for Waji to think about. Pedicle screws have now been downgraded to what's called a Class 2 FDA medical device. Puts in the same category as a lot of other orthopedic hardware that we use. And so each device that we use is either FDA approved for a certain indication or not. We can still use whatever we want, and it's called under the practice of medicine. So as a physician, we're allowed to use whatever we think is necessary, and you need to be able to back that up with some scientific evidence. So, literature based or, be able to reason or defend yourself, basically. So the other way out of the, if you don't have FDA approval for that indication, other way you can kind of defend your use is through what's called an IDE. So, investigational device exemption, kind of like some of the trials that we're running, for example, like that Barricade or other things that may not have been approved by FDA yet, but are exempted because they're sort of being investigated. A couple things I can think of is like a pedicle lengthening osteotomy device, and the annular closure device. So there's a few things out there. Here's an example of what can go wrong. So you can see here on the left. Can you guys, let's see, one of the residents. See, Peter, can you see what's wrong in like these on the leftmost CT scans?
Yeah, I mean, your pedicle is coming out the anterior aspect of the vertebral body and your aorta is right there.
Exactly. So screw penetration in the aorta, the thoracic anatomy with the left-sided pedicle screws, you got to watch out for that. And some people will put in shorter screws on that side for that reason, but I think careful sort of consideration of your imaging is going to be important. Here, there's examples of screws going straight through the canal. So, one side is, maybe it's two different people doing it, who knows, but you got to really watch out for your trajectories. You may think you have, the right starting point, but if you're operating on this side and you're relying on someone for the starting point over here and you can't accurately see it, it's going to be a problem. Here, this is in the cervical spine. You can see there's the transverse foramen here, and then what lives here, the vertebral artery. So you put in a screw that's too long, can have inadvertent vertebral artery injury. So, basic technique for screw placement, we're going to expose out our starting point in a relevant anatomy where we are in the spine, so cervical, thoracic, or lumbar. There's different things you look for. You need to actually breach that outer cortex of the dorsal, either lamina or facet, or wherever you are, lateral mass. And then you need to cannulate that tract with either continuing with your drill safely or using a blunt probe, or you can use a sharp or curved probe. Some people use a curette. Either way, you need to cannulate the tract into the pedicle. You can check for breaches with a small ball-tip probe, and that tells you, whether you be breached into a place that's not structurally sound. So either laterally out into the space, medially into the spinal canal, inferiorly into the dural foramen. So, and then you check again for breaches and place a screw. So let's just kind of march down the spine. Occipital cervical fixation. Now, we're not typically used to this area. This is kind of in terms of like skull anatomy, right? We don't really think about that all the time. That's kind of like what neurosurgery thinks about all the time. But the things that we need to know in terms of being able to put a plate safely on the skull, and you do this anyways when you're doing PCFs, right? And you're seeing how far up you need to go. You're gonna the big bump on the back of your head that you would feel on everyone. This is the EOP, external occipital protuberance. And the, I guess the densest part or the biggest spike on that has a special name. It's called the inion, I-N-I-O-N. That's where the nuchal ligament attaches. So it goes all the way up to there. This is the densest part of your skull in the back, in your occiput at least. The superior nuchal line it kind of emanates from the EOP, and that's where a lot of your muscles attach. So your sternocleidomastoid, traps, sort of the outer layer. then you have this inferior nuchal line as well here. It's another sort of a landmark. And then if you can sort of imagine this, the inferior nuchal line, this little trapezoid in between, that's kind of your landing zone for safely putting occipital bolts, screws, plates, whatever you want, with the safest part being here in the middle. Because if you kind of flip, you know, if you imagine the inner aspect of the occiput, you have, you know, the dense ridge from the supranuchal line, EOP, and then this internal occipital crest. So if you're trying to aim midline your screws into there, that's where it's going to be your densest part of your bone. And typically, you know, we probably don't do this, but neurosurgeons, if they do like a posterior fossa decompression or like a suboccipital kind of decompression, this is where they do it. We don't want to go up past this inferior nuchal line, but it's generally kind of this area. You know, so when you do full exposure, you need to expose the occiput at least enough to put your plate. Okay, so we'll go through the rest of this exposure, but basically you do the rest of your cervical exposure, posterior cervical exposure as well, taking care that, you know, not injure the vertebral artery at C1. You place your plate in that landing zone kind of I mentioned. With typically the newer types of plates have 3 midline holes to put screws in the most dense area, and then this side kind of protrusions to capture rods. So, so what we can see here is to safely start with, you mark out where your plate is going to sit, and you may need to burr some of this anatomy to make it sit flush against the bone. And then what you do is measure first about 8 to 10 millimeters to be safe, because, and you should look at preoperative CT anyways because of variable anatomy, but 8 to 10 millimeters is a safe depth without protruding kind of into the inner table, it's called. And I guess what's, you know, the major dangers here are that you have a confluence of your sinuses there, so you can get pretty significant bleeding if you hit, you know, the confluence. At 8 to 10 millimeters, then you take your drill out. You can then take a ball tip probe or safely feel the inner table there. And then you can keep going. Some people, I've typically only got up into the inner cortex and have never breached it. Sometimes you may accidentally breach it. Other people talk about safely doing it, going through it with the drill to get a bicortical purchase. There's probably a variation technique there, but you go up in 2 millimeter increments to be safe. Now, once you have your plate on and you have your 3 screws midline and the rest of your subaxial fixation, you can kind of lay your rod. This is the hardest part. Honestly, it's not just putting the plate on it, but it's getting the rod with this crazy wicked bend here. It can be pretty hard. You can a lot of times skip C1 screws. If you have good C2 fixation and then good, depending if you're going to C3 or C4, you can skip this, which makes it a little bit easier to line up the rod because you can sit a little bit higher. But that needs to be, I guess, pathology dependent, depending on what you're trying to accomplish. So this is kind of the end result once you have the rods in place. This is what the X-ray kind of looks like. These screws are going to be anywhere in the 10 millimeter range, 8 to 10. So next, we're going to talk about C1 screws, and specifically, you know, I'm saying historically here, there may be people who still do these transarticular screws, which are C1, C2 transarticular, you know, fixation. And basically, the technique for this is to go from the dorsal aspect of C2 up through the C1, C2 joint into the anterior aspect of C1. So you can see this is the trajectory of the screw. It starts here, crosses the joint here, and goes into the anterior aspect of C1. This is kind of fallen out of favor, for a couple things, a couple reasons. Because just getting the angle for this and doing this, I think, is pretty hard. You need to be able to angle, you need to create a bigger exposure than you normally need to, because you can imagine your skin incision is going to be way down here just to get the angle for the screw. B, you have to really pay attention to vascular anatomy. So there's a high risk for vertebral artery injury here. And also, if you have in cases of, let's say, inflammatory arthritis or trauma, or for whatever reason that with a lot of instability, the relationship between C1 and C2 with the facet is not normal, or if it's pretty displaced, then you need to have some sort of reduction before you can even safely place the screw, and you might have trouble with that. So the kind of next evolution technique has been doing C1 lateral mass screws. So C1's a funny bone. It sits, it's like a little, I think it was kind of like a little link between your heavy skull and the rest of your spine, and C2 is like a much larger bone. So C1 is like a ring in between. It doesn't have a vertebral body. It only has a small anterior arch. It has these huge lateral masses. There's no real pedicle. It's just lateral mass because, you know, the superior facet kind of articulates with occipital condyle, inferior facet articulates with C2, and then, you know, it's just this area here. But that provides a corridor for you to place a screw safely and get fixation. So that's where we place our C1 screw. There's obviously a dangerous anatomy here you need to watch out for. You know, number one being the vertebral artery runs on the top of C1 on the sulcus here before taking off into intradurally into the cranium. So, you know, the other thing you need to watch out for is also the C2 nerve root, which goes underneath into the C1, C2 neural foramen. And the other thing, kind of as we mentioned, like let's say, for example, in cases of trauma, where, you know, doing a C1, C2 transarticular screw would be kind of troublesome. This, you know, by palpating anatomic surface landmarks, you should be able to identify this kind of safe corridors of bone to place a screw. And especially when you have weird anatomy and displacement of your C1 lateral masses, when you're exposing, you have to be extra careful because you may not find things in the right position or where you would expect them. Here, examples of like where's the lateral mass trajectory. So it was initially, these are called Harms technique or Goal Harms technique because they're the first to describe this. They talked about going 3 to 4 millimeters lateral to the medial edge of the lateral mass. So by the medial edge of the lateral mass, go to 3 to 4 millimeters lateral, and then you aim slightly medial. That's how they describe it. There's other techniques to describe translaminar. You kind of go through the lamina because a lot of times this can overhang. But the most common way, and there's kind of a thing what I've adopted is kind of a a notch technique, whether you need to take off a little bit of this overhang of the lamina with like a little kerosene, or you may not need to. And the starting point you can identify by finding the lateral edge of the lateral mass, the medial edge of the lateral mass, and it kind of upslopes so that in the middle there's kind of a ridge. I usually just trying to find the middle and mark that as a starting point. The C2 nerve is running through here. Typically, you can kind of move it out of the way and hold it there with a Penfield or something safely out of the way so that when you can get your small burr for a starting point, you don't wrap it up. Remember, you're going to be using fluoroscopy to direct your craniocaudal kind of angulation. So I don't worry too much about that. While looking at it, I kind of look at it on the fluoro to line up the cranial caudal angulation, but the medial lateral, that's all you, and you have to make sure you're not going too medial into the spinal canal, but you also don't want to go lateral towards the vertebral artery or superior and lateral, and you don't want to go too lateral because then you may also like get a shorter screw because the anterior aspect of the arch kind of slopes this way. So here's an example here, taking like, let's say a Penfield, moving the nerve out of the way. It's kind of usually crosses more like this. So it's kind of difficult to move it out of the way sometimes. You got to feel that middle of the lateral mass. That's your starting point. This is I found this to be a nice picture because this blue represents, you know, kind of huge venous plexuses. So like when you're exposing this area underneath the lamina of C1, it can bleed a lot. So a lot of times, you're packing it away, waiting. You can work on the other side. That's where we pack it, wait, go back to the other side. So it can take a little while. And then if you find that the C2 nerve root is just, you know, in the way, draped right over the facet joint, you're unable to get your landmarks, you can sacrifice it. The only, you know, issue will be sort of loss of sensation on the posterior aspect of the occiput. It can be bothersome to some people, but if you have a screw wrapped up in it and you have more of a neuralgia type picture, then that could be more bothersome for the patient. Here's an example of an exposure, this being the EOP up here. This is C1, C2. Here is the midline of C1. Now, we always say don't expose with your Bovie or more than 1.5 centimeters from the midline, because that's where you run into increased risk of running into the vertebral artery. If your artery lives up here and hopefully kind of is already taken off to go up, into the foramen magnum, but to be on the safe side, you don't want to go up exposed with your Bovie more than that. The next step is you can still go safely elevate everything here if you use a periosteal elevator, and then expose the undersurface of the lamina as well. That way, exposing subperiosteally reduces your risk of catastrophic, or reduces your risk of bleeding, like venous bleeding, and helps you safely kind of expose this area. This is hard to picture, but it's kind of like where the lateral mass is going to be. These little lines right here. So that's, you can imagine, once you find that, you use a pen tool to march over medial and lateral and find the borders. Here's an example of C1 screws already in there. I usually think about the average length of the screw within the lateral mass is about 22 millimeters. And then whatever's protruding out of it, because lateral mass is way down here, right? This is like 22 millimeters. And then there's going to be some portion sticking out. It's usually about 10 millimeters or so. That some people may not, but I've been using kind of a smooth shank, so that way it doesn't irritate the nerve if it is, if you didn't sacrifice the nerve. So if you add that up, it's usually around 32, 34 millimeter screw that you'll be using. And you can usually put a 3-5 screw in there. Now, dangers that we talk about, obviously, if you do too long of a screw, the internal carotid artery sits there. You're safer if you're towards the medial third of the lateral mass. You're less safe if you're in the outer 2/3. And the more lateral trajectory you have, a higher risk of hitting the internal carotid in the anterior aspect. Again, there's also been documented risk of palsy with a hypoglossal nerve. And then again, C2 neuralgia, as we talked about. Here's an example of a screw getting close to the internal carotid. And here's the example of the hypoglossal nerve screw tip getting close to it. Now, next most important point to make is a C2 fixation. This can be pretty tricky. So, there's two ways of doing it, three ways of doing it. One way is pedicle screw. So C2 also has a very interesting anatomy. There's a inferior facet, there's a superior facet up here, and it has this long elongated isthmus. So remember, this is very different from C1, right, which is like a ring, no body. Here there's a vertebral body and this long isthmus, or the pars. So we can use this pars to our advantage to use for fixation, this long tract, and then there also uses pedicle here. So the green here shows like a pedicle screw tract, blue shows a pars screw tract, and the yellow shows the laminar tract. This purple is this transarticular screw that we talked about earlier. So going back to where's actually the pedicle, you find when you expose the C2 spinous process and you safely come up with your Bovie here, I switch over to using, again, a periosteal elevator to kind of elevate the rest of the tissues safely towards the spinal canal. And you can find where this superior lamina ends, and you kind of fall over into the medial aspect of the pars. And when you kind of slide up into the medial aspect of the pars and you feel the pedicle, the medial border there. So once you identify that, you can get your landmarks for your pedicle screw. So your cranial caudal starting point is going to be kind of this superior edge of the lamina where it falls off. And then I like to start a little bit more lateral than they're picturing here, sort of kind of aiming towards where I put my Penfield in there in the canal, and see exactly where the medial border of the pedicle is and aim towards it. it's going to be around that 25, 30 degree kind of range. Again, you can use preoperative imaging to help, and fluoro for guiding your angulation. So again, as we talked about, pedicle C2 screw about 25 to 30 degrees, and sagittal, or sorry, the axial plane from medial lateral, and then the sagittal is usually guided by fluoro, but somewhere around 30 degrees. Now the other one we talked about is pars screw. So pars, because here's the inferior facet, there's a superior facet, there's that little quarter of bone we can use. This starts at a lower point and in the sort of dorsal bone column kind of C2, and a little bit more medial. And so again, more medial and lower. So it has a kind of a more straightforward approach. The other thing we got to watch about when you think about C2 is you have to really know about where the vertebral artery is. There's two things you need to worry about: how medial the vertebral artery gets and how high does the vertebral artery go. So you'll hear the terms high riding vertebral artery and medialization. There's studies classifying it. I don't really go by the classification, but I'll show you a couple of measurements which are helpful. I think this one shows C shows how medial it gets. Okay, so this is obviously pretty safe because it kind of starts there, so you don't need to worry about if you start your this is looking at the front here. So if you kind of start your pars screw and you kind of come up this way, you should be safe. But if you start your pars screw here, come up this way, you might be in trouble. Or pedicle screw, same thing. And a high riding vertebral artery means it goes up higher than normal. So that again, if you start like a pedicle screw over here and aim this way, you might be in trouble. This is kind of a histologic section, kind of demonstrates this pretty nicely. This is where your pars screw would go. See, that's a pretty small corridor. Or pedicle screws kind of start out here and kind of come in. I really like this picture because it kind of demonstrates that. It took me a while to kind of understand this, but let's say you're looking at the left side of C2, that's where this is, and you kind of slice it. This is where the vertebral artery is coming. It comes out this little, they call the vertebral artery cave, because sometimes this can be very variant in different anatomy and different people. And then as it comes up, this is the V3 segment of the vertebral artery. So you got to pay closer attention to this. This, let's say, I don't know what the starting point is, but typically a pars screw would be kind of down here, and this would be the safe corridor you're aiming for. And you can imagine this is kind of your rate limiting step, right? Whether you can use this or not, and then how big of a screw you can use and the length you can put it in. So if this is too small, you might need to use a smaller screw. And these are the measurements that you want to use. So I always take the sagittal CT cut here. I think this is the most helpful because as you go through the sagittal, these double, the 2-star area is what's called the isthmus height. This 1-star arrow is what's called the, sometimes you'll hear it as an internal height or superior pars height. This is what I look for in terms of when I place a pars screw, because that's what I like to do more rather than the C2 pedicle screw. And if this is less than, like 3 millimeters, then you're gonna have a tough time putting a screw up there. Of the length that you want. You can certainly put a smaller screw to like right here to be safe. But here's an example of the sagittal CT showing pretty decent height for the superior pars. But this isthmus of the pars is pretty small, so it'd be kind of hard to sneak a screw up that way. And here, the axials show the pedicle width. So for example, if you can imagine, it's hard to kind of outline it, but like if you can imagine starting the screw out higher up and more laterally, you can aim one in, as long as his height's pretty good, or the width is pretty good. And so here, this guy has very dysplastic pedicles. There's no way you're gonna put a pedicle screw in this one. And very hard to put a pars screw. So your options are either a very short pars screw here, like it's called inferior pars screw. You can get away with like a 14 millimeters. Some people will describe like a superior pars screw, like a very small one here. Either way, not great fixation, right? What I was going to say is typically a C2 pars screw. I try to use a 3.5 millimeter by 22. That's if this is safe, you can usually get about like a 22. if it's unsafe, you can always be get like a 14 millimeter in. And then this is just sort of describing there's if medialization high writing wasn't bad enough, there's like other things that you can worry about. So there's like fenestration of the vertebral artery. There's another intersegmental artery. So basically, you got to pay close attention. This is an example of fenestration, like another big branch coming off. This is what I was talking about. This cave, vertebral artery cave in C2 can be very variant in people, so pay close attention. Especially, from what I've seen in the literature is like people with Klippel files or other, anatomic abnormalities may have a higher association with these. Example of a high writing vertebral artery getting in the way of doing any pars fixation. Here's some examples of things that can go wrong. Here's a screw getting into the vertebral cave here. Here's one going directly at the vertebral artery. Here's one going in the spinal canal. So again, this just illustrates that you have to be pretty careful and things can go wrong pretty quick. So what's the bailout when you can't do the pars or the pedicle? You can do a laminar screw. Now, to be honest, I haven't done this, but I have seen multiple people kind of describe this as a great way of fixing C2 if you are unable to do the above mentioned. So the starting point is kind of at the inflection point between the spinous process and the lamina. And for example, you start on the left side at the inflection point and you're kind of paralleling the contralateral lamina. And same thing for the right side, you're paralleling this lamina. And typically you can get about 2 screws in, and here's a CT scan showing their trajectories. And you can get about a 30 to 40 millimeter screw in lengthwise. Now moving on to what we're probably a little bit more familiar with, subaxial lateral mass. Now, yep, Baji, you say something?
Yeah, so as a quick question for you. So routinely, if you're planning on instrumenting C1-2, you get a pre-op CT?
Yeah, I would.
And then when would you get an angio?
That's a good question. If you see anything abnormal with the course, I would think to get an angio. For the most indications I can think of C1-2 fusion for getting a CT, you're going to get anyway. Most of the time it's trauma, so you have that anyways. Other things like if it's rheumatoid or like just severe C1-2 arthritis necessitating fusion, you're going to get a CT anyways for that. I'm trying to think what other, but yeah, I think CT is pretty helpful. And then the angio, again, if there's trauma concerns for vertebral artery injury, or if there's abnormal anatomy, like you see aberrant course on one side, I think maybe getting like from what I was reading, like a Klippel file deformity is kind of associated with these. So if there's a questionable issue on MRI, you may want to get it.
Thank you.
Yeah. This is kind of an annoying slide, so we'll kind of skip this, but this just shows you there's multiple techniques been described. I like to look over here and just when you expose the lateral masses, you just want to expose that entire rectangular block. I usually then divide it into quadrants and then find the center point. So expose the entire rectangular block and find the center. And when I find the center, I usually go 1 millimeter inferior, 1 millimeter medial, and then aim to the upper outer corner. So that eventually means you're going to be aiming 45 degrees kind of up, as well as maybe about 30 to 45 degrees lateral. This picture shows you that in order to get into this actual angle with the lateral mass, you're going to be bumping up against the SPs. So it can be kind of hard to get that actual trajectory, and you don't want to be sort of compromised with, getting bumped off by the SP. In which case, you might need to nibble off a little bit of it just to be able to, because you haven't started your decompression yet. You want to get all these tracks first, but leave enough of the SP to grab onto to take off the lobster tail later. So the structure is to avoid when doing subaxial lateral mass screws. You want to go aim up, so you get out of the intervertebral or the neural foramen, you don't hit the nerve, and you want to aim out so you don't hit the vertebral artery. C7 pedicle screw. So this also applies to all the other subaxial cervical pedicle screws. And I think I've seen, some people describe them putting them with navigation. C7 typically we can do because it's the biggest subaxial screw, and we can do it with like a laminar foraminotomy technique. So pedicle is usually just slightly lateral to the center of the articular mass, and then it's up close to the inferior margin of the IAP above. You do a small laminar foraminotomy, and you can put a nerve hook in there and feel the pedicle. I usually like to feel the superior border and then the medial border, and that way I can sort of localize where my starting point would be, kind of up close to the IAP and middle of the articular mass. And then you got to aim about 25 to 30 degrees medial, and then your cranial-caudal angulation is going to be based on your intra-op imaging. But C7, you're going to be pointed down, so you just got to aim how much down. The other trick I've learned is you can parallel kind of this lamina, or be perpendicular to your ipsilateral lamina is one way to get your trajectory right. If you can also just skip C7 pedicle screws and do lateral mass screw, and then if you're going to go down and do T1 and T2 screws. So the C7 pedicle screw, again, this should kind of shows that technique. And then the one thing people talk about is also like a funneling kind of technique. So if you have trouble finding it, you can kind of burr out a little bit more, but as you go in, keep it small. The way I do it is actually I use a like a 1.7 millimeter burr, or I think here we have 2 millimeter burrs. So use the smallest burr possible, and then start here, and then just kind of keep bouncing. Every so often checking with the ball tip to make sure I haven't breached. And then once I'm in like 18, 20 millimeters, I should be into the vertebral body. And if I haven't found a breach, then I'm good to go. And then I take my tap and tap to the appropriate depth. These screws are usually around 22, 24 millimeters, and you can tap to that appropriate depth there. Cervical laminoplasty, quick. So,
Hey, Sri, can I jump in and ask a quick question?
yeah.
So give me your thoughts on a couple things. Number one, subaxial pedicle screws. So
Yeah.
where the is, right? C3, 4, 5, 6. What do you think current state is on feasibility, and is it worth it?
I think it's feasible based on what people have shown, especially with the use of navigation. I think it's, at least seems like it's being done in Europe more than here, at least as far as I know. I think from what I've read from those kinds of papers, it seems doable, and it seems, if you're willing to take the time to do it. I don't know how much it adds. Maybe if you're doing like a C3 to T1 construct, maybe it adds more strength. But again, if you're doing a C2 to T1 or C2 T2, then I doubt it. I think you can go much quicker with lateral mass screws and save yourself time. And again, the safety, the medial breach could be pretty catastrophic there, or laterally into the vertebral artery. I think I'm gonna only do C7, in PCFs, and then lateral masses every other level. Quickly about laminoplasty. So laminoplasty, there's two techniques. You guys might have heard midline French door. So you kind of split the spinous processes and then open it up to expand the canal that way. Or the more traditional way is a open door. So you create a trough all the way through the bone on one side, just like you would with a PCF. And then on the other side, you're creating a unicortical trough. So you're just breaking the dorsal cortex, getting through the middle cancellous layer of the lamina, the laminar lateral mass junction, and you're leaving the inner cortex intact, so you can kind of hinge it open. This is an example of like after you create that unicortical hinge, using your curette to carefully elevate that lamina. You want to be careful here because this is the fuzziest part. You break that lamina over there, now you're in trouble. Now you just have like a free floating piece. And there's salvage techniques. If you end up breaking this, there's like a plate you can put on here. But some people just talk about taking it all off and switching to lami fusion. So here's another good picture. You burr through one side, you create a unicortical trough on this side and hinge open that way. And there should be enough elasticity here to be able to kind of hinge open. The goal of laminoplasty here is always healing on this side, heal on the trough side. This part doesn't matter. So you can do lots of things here to keep that open. And so what's described here is sometimes people wire. So you see like they wire the spinous to the facet, or some people put like an allograft spacer in here. The more common thing to do is just use a plate, kind of strut this open. All this plate is doing is just kind of strutting it open. You put one screw in here, 1 or 2 screws in here, and or usually 2 like 6 millimeter screws in here, 1 8mm screw in here, and then you put some monograft in here and let this side heal. That's kind of what this ends up looking like. These are called arch plates, and there's a wide variation of these. I like this technique. This is the midline French door technique. I have not done this, but you know, similar concept, right? You just kind of, you're hinging on both sides, so you got to create troughs on both sides and then split it in the midline. Let's switch down quickly to the thoracolumbar, so thoracic pedicle screws. So you know, they're still, dangerous anatomy you have to worry about here. Not as much as, let's say, you know, the upper cervical spine, but you still have the spinal cord. It's still cord level, and then you have anterior, you have major blood vessels. So in order to get instrumentation for thoracic screws, you got to dissect out to the edges of the TPs all the way out, because that you need to, again, identify surface anatomy, right? So here's pedicles, and thoracic pedicles are kind of strange. They're very like long and ovalish, so their height is a lot greater than the width. And to be able to see the pedicle, or see the starting point for the pedicle, you need to do fascectomies at each level, remove cartilage. So we'll talk about that here. How do you know where is the pedicle? You need to first find medial lateral by using the superior facet. In order to see the superior facet of that level, you need to take off the inferior facet of the one above. So you can either use like a osteotome to take this off, or burr, and you need to burr off at least 3 to 5 millimeters here just to see this SAP. You kind of use a pen feel to just feel the sides. Now, what I have here is that you have the midline of the facet. You never want to start anywhere near the medial aspect of that midline. So you want to be on the lateral aspect. So that's what these lines are here. Now the craniocaudal starting point is going to be dictated based on what level you're at. So I have a chart on the next slide I'll show you, but that's going to dictate where you're at. Sometimes, here's another technique, I kind of create a box and I'll show you the starting points in there. But typically, this is what is called a Lenke chart, and just sort of maps out slight variations of the starting point of the thoracic pedicle screws as you go up and down the thoracic spine. One mnemonic I was told that I think really helps me is 12, 1, 2, 3 equals mid TP. So you find the TP of T1, T2, T3, the midline, and then remember you have your mid facet line that you don't want to be medial about, so you're going to be lateral to that, and then you're going to be cranial-caudally in line with the T3, so you're going to be starting about right here. Same thing here. So then if you can imagine from T1 to T8, 8, 9-ish, you're going to be marching up like this. The starting point kind of goes up this way and then comes back down as further as you go down. Another 7, 8 mnemonic is 7, 8, 9 equals top of the line, and that means that you're at the top of the TP and the facet. So, sorry, top of the TP, and you'll be in the lateral aspect of that facet line. And when I go back here, I'll show you what I mean. So mid TP, this is the top of the line. So this is the box you're going to be within craniocaudally. This is the box you're going to be within medial laterally. So all your starting points are going to be in this box, and you got to find the correct area depending on level. Here's an example of, once you take off using the osteotome or the burr, finding the area of the starting point for the pedicle. You can, another technique is if you're unsure, you can rondure this area, and I kind of like this. You either rondure or use a burr, and you can find the cancellous blush of the pedicle. So it tells you where that starting point is. And if that's not enough and you're still having trouble, you can do a small laminoraminotomy as you would in cervical spine. So use a nerve hook to palpate the medial wall of the pedicle. Once you find that starting point, you use a curved linky. I think is the safest way. You point the tip away. You kind of medialize your hand so that you're kind of aiming towards the medial border, but you have the tip away so you won't breach. Once you insert it about 15, 20, you know you're at the junction, the nerve center junction into the body. It should be safe. Now you can flip it around, point the tip the other way, and get down to about 35 or 40 to be safe. Actually, you don't even need to go that far. But typical screw length is about 40 to 45. It can be as short as 35. Again, highly variable anatomy. 5.5 or 6.5 screws typical, but you may need to use 4.35 in other patients. The other thing we'll talk about is very small pedicles. You may not be able to cannulate this, so you might have to do what's called an in-out-in technique. So you start in, you might breach laterally along, you might be out of the body. And then with the thoracic spine, you have the ribs coming in and you have the costic-vertebral junction. So you have maybe going through the joint with the rib there, and then you come back into the body. So you may feel like you're all in bone. You think you might have nailed it in the pedicle, but you might have had an in-out-in screw. It still feels pretty good, like rigid. So angulation of thoracic screws, medial lateral. We know up at from T1 all the way down to T12, you're using less of an angulation. Once you get down to T11, T12, it's basically straight in. So T1 and the rest of the spine is more medial, but T12 is almost sometimes like basically straight in, can be even look like it's almost going lateral sometimes on the CT. So these are T12 that are very hard screws to put in and without getting breaches. And you'll hear terms anatomic trajectory and straightforward trajectory. Straightforward kind of mirrors the end plate, and this has better pull-out strength. So this is the kind of technique that I use. Now you can get pushed out with to lateral breaches pretty easily if you don't take off enough of this TP. So this is an example here. There's some bone here, and that wasn't resected. So this was put in, and there was a lateral breach. So you got to take off enough of this so you get enough of a trajectory to get that medial trajectory there. Some pearls for improved fixation. You can under tap by 1 millimeter. Use the largest screws you can, so you have the largest outer diameter, because that increases pull-out strength. And again, the length of the screw, the maximum length of the screw all the way up to the anterior cortex, or 80% of the way up there, can increase your pull-out strength. Screw convergence also increases pull-out strength. And then this is hard to avoid sometimes, but you don't want to be putting in screws, removing them, checking the walls, and then putting them back in, because that automatically decreases your pull-out strength by 1/3. And also hubbing your screw decreases pull-out strength as well. We talk about transitional anatomy at T12 and L1. It can be pretty strange. TL1 can have a sort of thoracic looking TP, and then T12 can have like more of a lumbar looking TP, and vice versa. So it can be kind of hard. You can use that funnel technique we talked about to kind of get to the base of the pedicle to safely find about the starting point. And the other things I've gotten in trouble too is make sure you pay attention to kind of the starting point, and it's not like way off base from your rest of your screws. Otherwise, you're gonna have trouble with the rod. Lumbar pedicle screws, we're a lot more familiar with, right? You expose out laterally, traditional open technique.
Hey, Sri.
Yeah.
Sri, you mind if I jump in just again real quick?
Sure.
So the thoracic screws, I was always taught, and I think I do this most of the time,
Yeah.
especially mid-thoracic and higher, is to go shorter on the left side than the right side.
Yeah.
Because of the aorta. What do you think? Is that something that we should be able to overcome with just good technique, or do you think that we should always have a little bit of margin of safety on that left side?
So it's funny you mentioned that. I've seen certain people do that automatically. Left side all is 5 millimeters shorter, and I kind of never understood it. And I understand if you look at like the anatomy, people with like true scoli have weird shaped vertebral bodies. I think in those settings, depending on I guess what it would be, the convex side might be more abnormally shaped. I think that makes sense. You might have a higher breach rate, but I think looking at the CT scan makes sense, because from what I found with like straightforward people with normal anatomy, you're doing this for trauma or something, I don't see any reason to undersize that left side. But there are people with
Yeah,
funny
I
shapes.
think, yeah, I
Yeah.
totally agree. I think you need to look at the aorta. Each person's going to be a little different in where it's laying. Sometimes the aorta is way lateral, right? And then shortening it up by a few millimeters won't matter. If you're lateral, you're lateral. It's those ones where it's sitting just anterior lateral. And that's, you know, again, where over the years you see enough pedicle screws that were too long. I think, you know, you start to hedge back a little bit. But I've also seen the opposite happen where people just start going really short on their implants, you know, like 35 millimeter screws in bodies that can handle a lot more. So.
Right. Yeah, I feel like 35 should be kind of like the lower end of what we use.
And then what about pedicle expansion? I know I've sort of I was taught you can take a narrow pedicle and tap it up and then fit a bigger screw in. Is there anything to suggest anything around that? Is that reality, or are we just blowing pedicles left and right?
I think that holds water for, you know, I think you can safely do something like, let's say, like a 5.5 pedicle to a 6.5 pedicle. I can buy that if you kind of tap it and you're in the right track. I don't know about like those smaller dysplastic pedicles, like the ones that are like 4 millimeters or less. They're just funky looking. That doesn't make any sense to me. Like, it's hard enough to get your lanky in there in the right track, and the fact that the pedicle is being expanded on all sides by the tap, I don't think so. I think you're probably blowing out laterally and kind of getting what fixation you can get.
Yeah, I mean, the nice thing is the post-op CTs, you can't tell at all. It's just screw anyway, so you convince yourself you're through. I think that idea of pedicle expansion is a lot more reality in the pediatric population, you know, or in the younger adult where the bone maybe has a little more, you know, plastic deformation to it. In our osteoporotic patients, I'm not sure that's really what happens, but nonetheless, I think the take-home point for YG and for everyone who's training is you may go on your CT and measure a 4 millimeter pedicle, but we'll easily put a 5.5 in there still.
Right.
Right. Sorry to cut you off. I'll let you keep going here.
Yeah, no, I'll speed up. I've been rambling a little bit. So, you know, lumbar pedicle screws we're a little bit more familiar with. So open anatomy, we expose all the way out to the TPs. You find the midpoint of the TP. And I was always taught you look for the confluence of TP, pars, facet, and usually you find something called the mammillary body there. And that usually is a good clue of where you can have your starting point. Sometimes you need to be a little bit more medial to that mammillary body in between kind of the upslope of the facet and the mammillary body, but that's usually a good starting point for, you know, creating your burr hole, and then you can carefully cannulate that. I like to use a blunt tipped probe. So the Steffi probe I find pretty nice with these big lumbar pedicles. Otherwise, you could use the same technique with the curved Lenke. Finally, I mean, people do this either before they start their decompression, like to use Surfing anatomy, or you can do this after decompression, and you have the advantage of feeling the pedicle walls that way too. The lumbar pedicle angulation gets higher as you go towards L5. So by the time you're at L5, it's about 25, 30 degrees in the medial angulation. Lumbar pedicle screws, I was always taught L4 to the floor, but it can be 3 or 4. So check your trajectory intraoperatively. The L5, T1 to L4. So like we talked about, the thoracic pedicles are really tall and not as wide. So your rate limiting factor for what size screws you're going to use are your width in your thoracic spine. In the lumbar spine, or at L5, that's the first pedicle where like the width is generally more than the height. So you can put basically any size screws you want in the lumbar spine. You know, obviously depend on patient anatomy, but I usually like to go with 6.5 millimeter screws, or 6.0 or 7.0. And then at L5, you can even go higher if needed. Cortical screws, briefly touch on that. This is a technique that's helpful in osteoporotic patients to provide better purchase and more resistant pull-out strength. So our typical pedicle screw angulation is this, medial to lateral. The cortical screw angulation is from lateral to medial, and it goes from inferior to superior. So you're aiming up towards that end plate, superior end plate. And again, the type of screws that you use are smaller pitched. So again, think about trauma principles. These are smaller pitched threads to get better fixation of denser bone. Here's an example here. Sorry, I skipped the starting point, but basically you can find the midpoint of the SAP is like kind of your medial lateral starting point, and then people describe 1 millimeter underneath the TP, and that's your starting point. You aim up and out. So for left-sided pedicles, so it'd be kind of at the 5 o'clock starting point, and 7 o'clock for vice versa the other side. Here's an example of pedicle screw fixation. Here's an example of cortical screw fixation. Again, same thing here. This is what it looks like on CT. Let's move on to sacral screws. So S1 screws, a little bit tricky in the sense that you have to expose, the S1 pedicles are huge, so you shouldn't have a problem with that, but you got to expose everything to get the right starting point. The infralateral corner of the L5-S1 facet joint, so the S1 facet, that's where you want to start your screw. So you want to make sure if you're going down the sacrum, you need to expose all the ala anyways, because you want to create your postlateral gutter. So you need to expose all of this and then make sure you find this point. What can get in the way? So you need to aim pretty medial for these screws, so about 35, 40 degrees, and the PSIS can get in the way. You see here. Sometimes, I've never had to, but sometimes you might need to take off a little bit of the PSIS just to get the angulation. Otherwise, you can easily be pushed and have a lateral breach. Now we talk about, bicortical fixation versus tricortical. Tricortical in biomechanical studies should been shown to have a much higher sort of resistance to pull out insertional torque compared to bicortical screws. So if possible, you aim up towards the sacral promontory and medialize it. Now, iliac fixation, pelvic fixation techniques, there's two ways: traditional iliac bolts or iliac screws, and then alar iliac screws. So we'll start with iliac screws. This is where the S1 screw went in. Now this is the PSIS, and the starting point of an iliac screw is at the PSIS, aiming down this column of bone above the sciatic notch, that we call sciatic buttress, aiming towards the AIIS. So there's a huge corridor of bone here. You guys probably remember from trauma principles like anterior column screws. This is a great area to get purchased. So typically, depending on how much overhang of the PSIS you can try to, some people try to expose traditionally kind of like over the top and find the entire thing. Other options, you could just kind of recess underneath, ronger out that area, bar out that area, find a way to kind of recess the screw head as well. And that way you find the starting point. You're going to be aiming towards the greater trochanter as a general landmark. To find a trajectory, you can use fluoro to find the teardrop and make sure you're in the right trajectory. And then after you put the screw in, you'll be hooking it up to this using a connector. Alar iliac starting point has the advantage of just using a more midline approach. So you need to go as lateral. It's going to be in line with the other pedicle screws. And you're going, this is the sacral ala. So you start with this lateral sacral crest in between the S1 and S2 foramina. So I usually find the midpoint in between these. Sometimes these are hard to see in intra-op, so I take a ball tip probe gently and identify where this S1 foramen is, S2 foramen is. If I can't see properly, usually there's this ridge, lateral sacral crest. You can kind of go just over it, or depending on what it looks like, burr out an area. And then my technique is I bring in fluoro. So on the AP fluoro, I put it in all the way up to the where the steppy probe, the blunt probe, to where I feel resistance, and then I know I'm at the SI joint. That's about 30 to 40 millimeters in. And then make sure I'm on the AP, I'm above the sciatic notch. Then I go over to my obturator oblique view with the outlet view. So that way, now I switch to finding the right corridor of bone, so I get my medial lateral trajectory. So the first part is getting the right inferior superior trajectory, and then the next is right medial lateral trajectory. And you want to be within this teardrop here, above the sciatic notch, in between the inner and outer table. As an example here, this is your outlet view, and this coming over top, that's your obturator oblique. And this is what you want to see, this nice, clear kind of teardrop. If you don't find that, and that's what you're representing here, this column, you're going to tilt your, adjust your C until you find this. And then finally, I think last thing, we'll just touch on fluoroscopic placement of screws. So MIS screw technique. Basically, before you make incision, I usually like to get a perfect AP of every level by lining up the superior end plate and the rotation wise with the pedicles and the spinous processes in the midline. Then I mark out the lateral border. Sorry, I bisect the pedicles to get the level there, and then the lateral border of the pedicle as well to get to mark out for each level. Then, depending on what levels you're instrumenting, I usually mark out 2 centimeters lateral to that. But again, with people larger body habits, you might need to be 3 centimeters or more from the lateral border of the pedicle, which is generally 4 centimeters or more from the midline. So starting points, I think we'll skip to this one. This provides more information. So I usually start mid or kind of around the 2 o'clock area for the starting point of the Jamshidi. You traverse, once you are comfortable with your starting point, you traverse the pedicle. You want to go up to 15 millimeters, not more than 20. If you're at 20 millimeters and you're past the medial border of the pedicle that you see, you likely have a medial breach. So I usually go to 15, check my AP, go a little bit more, and check to make sure that I don't have I'm not past the medial border here. If I'm not, then I'm safe. Then I go ahead and advance Jamshidi in, and then put in your guide wire. Then you tap over it, place a screw. They probably should pull that wire out before it gets stuck in there. But that's a kind of a quick overview. So I guess you guys have any other questions? I know we touched on some things, but kind of a lot to cover here.
Hey, Sri, thanks for putting that together. Really helpful. I think really good information. I think certainly for the residents and the fellows to look at. When you guys watch us operate, it may feel like we're going quickly and we're not looking for each of these bits of the landmarks that Dr. Divi just went over. But the reality of it is we are, right? We've done it. We've already looked for it. We find the other process and we go. But I think when you start, you want to make sure you identify those landmarks. And I would say even in an era of navigation where, probably in the next 10 years, we're likely to see more rather than less navigation. I think understanding what open landmarks look like are, still absolutely critical. Beyond being things that can be asked on the boards and on the in-training, they're good to have, in your tool belt. So any questions from residents, any questions from Wajid?
Hey, Sri, I just wanted to say a couple of things. Yeah, great job on the talk. Those graphics are really good, and they're probably one of the better sets of graphics that I've seen. So it's a great way for us to visualize.
From different textbooks. So.
Yeah, nice. Just a couple of notes. The laminoplasty, you made a good point. If you break the hinge side, which is pretty common, don't fret about it. I've done that many times. I've spoken with folks who do laminoplasty even more than I have, and they don't plate it. They don't worry about it. I think when you do multiple levels, that bone just tends to sit on the lateral mass and it tends to heal. So I have seen many different folks do certain things, but in general, surgeons are just leaving it and getting away with it. The second thing I would think, cervical pedicle screws. Yeah, the only times that I've regretted lateral mass screws subaxially are tumor patients. So I think if I were to, or the next tumor patient that I have where really concerned about bone quality, cervical pedicle screws may be an option with navigation. I do agree that for 99% of the folks who come to see us, the risks outweigh the benefits. But for the tumor patients, that may be consideration. And then the last thing I would say is, Alpesh made a good point about leaving the thoracic screws a little short on the left side. I do that pretty routinely, probably because I've seen so many just be so close to the aorta. So I'm not advocating that we should do that for everyone, but yeah, I would say that it's a practice that some employ, largely because of our experience, not really because it makes sense for everybody.
That's a good point.
Yeah,
Great job
and I
on the
think
top. Awesome.
especially in the mid construct, right? It's one thing if it's your apical screws. I think your apical screws, you want to maximize fixation. You do everything you can, biggest pedicle screw, biggest diameter. But if you're talking about mid construct screws, I definitely go a lot shorter on that left side. There's no reason to take even a small chance, because those are pretty dramatic, post-op CTs or CT angiograms that you sometimes come across.
What about when you mentioned with the Wellington, with the laminoplasty and the hinge side breaking, you still put on your what kind of plate arch plate do you use? Just kind of like one with like a spacer, or anything you need to do on the other side, like graft wise?
Yeah, I think laminoplasty is a pretty simple procedure in my mind, and we have done a lot of things as a group to try to make it more complicated, to try to improve outcomes that are already pretty good. So I just use a hinge plate. I've never grafted it. I don't think it needs to be. I think even if you break the hinge side, you definitely needs a plate, obviously, but you plate it as if you have the hinge intact. And yeah, my point is that trying to plate that side, I have tried to do that. It is a pain in the butt. And I would argue that doing that would probably double your OR time, it just isn't worth it. And, having gotten away with not doing it and talking to other people, again, who do more than me, more experience, and they don't do anything about it, just makes me convinced that that's likely not an issue. But yeah, I use a centerpiece, the hook plate. I'd highly recommend a hook plate of some kind, just so you can do it with one hand. If you use those straight on plates, you have to, you wish you had 5 hands to kind of hold the hinge open, hold the plate, then you got to drill it. And it's just, I don't think that's
with the drilling.
Yeah, I'd agree. I've broken so many of the other sides, I can't even think of it. It's not common, but I've done it enough times. And remember, the lamina are all connected, right, by the flavum. So it's not like it's going to be that loose. If you can spring up the level above and below it, then I don't think you have to worry about a broken hinge side. At least as far as I'm aware, there's really no data that says those little pieces of allograft that people stick in, it linked to a plate, that it actually improves outcomes, and for sure it adds substantial cost, right? Yeah. Which is probably the biggest advantage of laminoplasty, is that it's probably way more cost effective than lamifusion in some patients. So I would encourage folks maybe not to go after those structural grafts.
Yeah, I agree. I think from what I see, those structural grafts end up showing non-healing.
Yeah. The only trick that I've come up with that I've noticed over the years, is with the laminoplasty, for your plates that are lateral mass side, that are facing lateral mass, it can be easy to get those into the facet joint. And if you get them into the facet joint with enough motion, eventually they'll back out. So I think trying to angle them up a little bit is probably a good thing, or just going shorter, because those plates don't see a lot of force otherwise, right? So I think it's reasonable to try to shorten up the screw. I don't know if Wellington, you've seen that with your laminoplasty screws.
Yeah, I agree. I think with time, you're just like saying angling that screw a little bit more cephalad. And yes, I've done that over time as well. I think the older guys don't think that the screw is long enough to get into the facet joint, but I've seen otherwise as well.
All right. Well, listen, we're at 5:40. Wajid's overwhelming us with his questions tonight, so we're gonna have to cut him off and cut him short.
Cut off Wajid.
He knows it all, man. He knows it all. He doesn't need any more
Stop
questions.
asking so many questions. We have to rip on the current fellow. We miss our old fellows. Hey guys, everyone be well. I think our next get together is in a couple weeks. Is Journal Club, which will be our first one for the year. Wajid's got a bunch of great articles pulled that we'll read. Some of them we're going to focus on content and thinking about how we apply that findings. A lot of what we're going to discuss is more on the methodology side. So we'll make sure those get sent out soon to everyone. And then YG, if you can work with the residents to, sort of assign articles. And then when we circle back, we'll review articles together. And even though we're on Zoom, like any good journal club, beer, wine, and spirits are more than welcome.
Sounds good. Thanks, Dr. Divi.
All right. Thanks, guys.
All right, Sri.
Thanks, Dr. Davey.
Thanks, everyone.
Yep. Take care.